Welcome to Talking in the Neighborhood. I'm your host, Tim Brown. This program is sponsored by Philly Neighborhood Networks, whose mission is to engage, educate, and empower our neighbors to support policies that put people and planet first. We'll be talking about some of those policies today as we explore the topic of healthcare. In particular, we'll be talking about the state of the U.S. healthcare system, what works, what's broken, and what we can do to fix it. More specifically, we'll talk about universal health care, how it works for other civilized nations, what it might look like instituted here in the United States, and what we can do to help get it implemented. Joining us today are two well-known healthcare advocates. First, I'm happy to welcome Dr. Walter Tsou from the Center for Public Health Initiatives at the University of Pennsylvania. He's a nationally known consultant on public health reform. He was president of the American Public Health Association, a former health commissioner for the city of Philadelphia, and currently a national board advisor for Physicians for a National Health Program. Welcome, Walter.
Thank you, Tim. Great to be here.
Also joining us is Chuck Pennacchio. He is a retired history professor at the University of the Arts. He's producer of the documentary Fix It, A Healthcare at a Tipping Point, a former candidate for the Senate, and current president of One Payer States. Thanks for joining us, Chuck.
Thank you, Tim.
Chuck, what should our audience know about One Payer States?
One Payer States is it's a network. It's a 501c4 organization made up of 22 states, clustered with states on the Atlantic and Pacific seaboards, in a smaller number of states in the middle. States that are leading the charge. So we're talking California, Oregon, Washington, Minnesota, Maine, New York specifically, that are leading the charge toward establishing a state-based universal healthcare system. And the idea there is to model what can be a successful pathway to a national plan. So One Payer States was founded back in 2009, among and between folks who are seeing the frustrations of trying to cross the finish line in Washington, D.C., and said, let's work on a parallel second track to complement what's being done at the national level and see if we can get instituted a model or two or three that will then help elevate the discussion and make it easier to pass a national bill. And so we came together as an organization to share best ideas, best practices, to create strategies for success. And so we're a vibrant organization now, 12, 13 years old. And we're all about working with everybody at all levels of politics.
That's great. We're going to delve into that a little bit more. But before we do that, I'd like to help orient folks to this discussion with a quick review of the state of our current healthcare system. Walter, you've been a practicing physician for decades, as well as the former health commissioner for our city. Is there anything that works well in the status quo?
Well, the current system works well if you're a member of Congress or you're the president or someone with great connections to the healthcare system, like other health professionals. But for the average person, no, the system does not work well at all. It costs too much, it covers too few people, and it hurts too many Americans. And the current system, frankly, you could not create a more bureaucratic, unexplainable system than we have in America.
That's interesting.
One of the big problems.
Yeah, it's interesting you say that, because I read recently that U.S. healthcare spending grew by about 10% in 2020, reaching just over $4 trillion. That's nearly 20% of our nation's gross domestic product, about $12,500 per person. That seems like an awful lot of money, yet according to a recent Gallup poll, there are 46 million people. It's 1 in 5 Americans reported that they can't afford healthcare services. And the ones who can afford healthcare services, people with insurance, are lower. Their outcomes are lower than many of our fellow first world nations. So what's going on here, Walter?
Well, you're pointing out a couple things. First off, the healthcare system is way overpriced. It is way more expensive than any other nation in the world. In fact, we spend somewhere between 40 to 50% more per capita on healthcare than the second most expensive country in the world. And you have to ask yourself, why is that? Why are we spending so much money in this country for healthcare? And yes, of course, people can't afford it because we are pricing ourselves out of the global marketplace for healthcare. So no one is happy with our healthcare system. It costs way, way too much. And it leaves too many people without health insurance. And even people who say they have health insurance find out that they can't really afford the copays, the deductibles, all these other things that are added on to their healthcare bill. And we have this crazy system where you're in network or out of network. And if you happen to be with health insurance, but you happen to see an out of network doctor, guess what? You get the full cost of getting care from that out of network doctor. So the system is incredibly bureaucratic and nonsensical.
Yeah, I'd like to get, that's sad. I'd like to get some clear on some terms bandied about to describe a healthcare system that covers everyone. And I've heard universal healthcare, Medicare for all, single payer healthcare. Chuck, is there any practical difference in these terms?
Essentially, they're the same if they take an honest approach to what they intend to mean. The terms have been used and misused and distorted, unfortunately. For example, the Affordable Care Act, Obamacare, is regularly referred to by the New York Times as universal health care, which is an obscenity, actually, for a paper of that stature to misrepresent and mislead people. Universal means everyone. It means all. Medicare for all means all. Single payer means all. Everyone's covered. The term single payer is somewhat confusing to some because it really is only referring to the funding side of healthcare, when in fact it's intended to address both the funding and the delivery of healthcare. So that's a term that sometimes is a little more difficult. That's why the preferred term right now is Medicare for all, because people are more familiar with the Medicare system. And Medicare for all would extend universal healthcare, single payer, they are synonyms, across the board to cover absolutely everyone from cradle to grave.
Right. So that's our single, that's what you're talking about when you talk about a single payer plan, right?
Yeah, that's right. That's right. Single payer means that there's one stream of funding that pays for everything. But in reality, there are countries around the world that we think of as single payer, but are actually in some ways multi-payer. But to Walter's earlier point, they're so far more efficient and they're regulated, and they strip mine out this gross profit, waste, fraud, and abuse that Walter was referencing. I like to refer to the funding monster here with these agents, the big four, the four horsemen of healthcare. This is the pharmaceuticals, this is the big hospitals, this is the insurance companies, and this is the medical, the equipment manufacturers, the four horsemen, the equipment, the hospitals, the insurance companies, and the pharmaceuticals. And they continually gouge people because they're in the business of what I call profit first. They bake in the money they're going to make before they even deliver a single service. And that's obscene. They don't put an emphasis on actual healthcare. They put an emphasis on the bottom line, and they're servants of Wall Street.
Wow, that's so. Are they? I mean, it just seems like collusion to me. Is that really what's going on here? Or are they just working? Are they working in consort, or are they working independently to generate their own revenue?
Well, think about this. Right now, there's something called the Partnership for America's Healthcare Future. And the Partnership for America's Healthcare Future is the lobbying arm to fight against Medicare for all or a single payer plan. And who are members of the partnership? It's the pharmaceutical industry, it's the for-profit insurance companies, it's Blue Cross Blue Shield. It was the AMA until doctors pressured them to say, get off of this. And it's, you know, they're basically the people, the durable medical equipment people. They're the people who are profiting, like Chuck said, out of this current system. And they love the system the way it is. They're making gobs, billions and billions of dollars for themselves. And of course, they make the system so ridiculously bureaucratic and unfathomably complex that only they can figure out how to do it. And of course, they're the ones who make profits out of the system. It's just incredible. And then to keep the system the way it is, they give literally billions of dollars in contributions over the last few years to members of Congress to make sure that they don't rock the boat. And so essentially they have paid off with their lobbyists, the entire members of Congress to keep the status quo.
Yeah, it seems like a pretty steep hill to climb for making some changes here. But right now, if you include everyone in the government, everyone in the military, people on Medicare, people receiving Medicaid assistance, we already have a sizable percentage of the population that's not on private health care, right? So how different will a single payer system actually be compared to the status quo? I mean, what kind of money can we save? Those sorts of things.
Well, right now, think about if you're the hospital doing the billing and a veteran comes in, let's say, and then someone on Medicare comes in, and then someone on Medicaid comes in, and then somebody with private insurance comes in, and there's like 1,000 different private insurance companies who could come in with all different rules and regulations about how they pay their hospitals. You have to have something like 700, 800 people just working in your billing department. That's not hiring doctors. That's not buying COVID tests. That's not buying MRI machines. That's billing clerks who spend their time pushing paper back and forth. 700 of these people, millions and millions of dollars wasted really trying to get prior authorizations and all these other rigmaroles that people have to go through just to get their approval for their hospital payments. And that's just the hospitals. And then you have the doctors with all their billing people and so on. I mean, the bureaucracy that we have created is such a waste. When you compare that to, let's say, Toronto General Hospital in Canada, which has a single payer plan, and they have like in their hospital, maybe 6 people who just do billing. That's it. And they spend most of their time doing bills of Americans who happen to get sick in Toronto. That's how ridiculous our system is. We could take all that money that we waste on the bureaucracy and administrative overhead and use it to actually provide real health care for the American people and to guarantee health insurance for all the people who have no health insurance.
Yeah.
And the 4 trillion you cited earlier, about
Yeah.
1.3 trillion of that, a third of that, is administrative costs, what Walter's talking about. It's a nightmare. And you take a look at the administrative overhead for Medicare, it's approximately 2 to 3%. Some people count the number a little bit differently, but it's radically cheaper to do a single payer system, streamlined, efficient, so that we can just get to the point where the doctor, the provider, and the patient is the center of attention, not the money. That's the problem.
Yeah, so it seems it's all about the money. I want to get to that in a bit, but Walter, you're the doctor here. We're in the midst of a COVID pandemic. Hospitals are at capacity in many places. Staffs are stretched to their limits. Would a single payer system have handled this any better?
Well, it's interesting. The Nation just published an article about why, if we had a single payer system, it would have greatly improved our approach to COVID. Consider, for example, a simple question. How many people have COVID? How many people have tested positive? And how do we track people who may have had COVID? And maybe in the typical public health world, we would identify their close contacts and we would get them tested and make sure that they don't have COVID. Well, we can't do that in America because who controls the healthcare database? It's these private insurance companies. All the information gets funneled back to the private insurance companies. And what do they do with it? If we had a national health insurance system where we could have a national health database, we would know exactly who got COVID, who tested positive. When you go, instead of having these paper cards that you have to figure out where you pull it out of your wallet and so on, you could actually have a QR code, which is what they have virtually in every other country in the world. They have these QR codes that tell you that whether you've been fully vaccinated or not and whether you've been boosted. They know that. In America, we can't figure this stuff out. Then actually think about how we would approach treatment. We would actually know which therapies work. Does ivermectin work? All these, and this hydroxychloroquine work? Well, we could have actually answered that question very quickly because we would know what treatments people received. And we could actually do the type of clinical trials that would actually give us the real evidence that we need to say this works, this does not work, and do this in a much more quicker fashion. Instead, we have these incredibly onerous ways of trying to figure this out, and we usually end up citing Israel, Great Britain, other countries' databases, because they're the ones who have a national database, and we can find out from their countries what works and what does not work. It's an embarrassment for a country that has Apple, Google, Microsoft, that we have such a failure of a national health database that we cannot even figure out how many people have COVID and what treatments work for them.
Right. Bottom line is we can save lives and we can improve lives dramatically with single payer. And just to take this, to cite this, a couple of statistics with coronavirus, we've lost what, about 820,000 thereabouts. We would have saved under a single payer system about 350,000 of those folks.
Wow, that's a real practical solution to a problem, it seems to me. Chuck, what would so I wanted to talk about practical solutions. Like, what would a single payer system look like in practical terms? In other words, what would change about how we operate now? Maybe you can walk me through what a patient in a single payer system might experience as opposed to what they go through today.
Okay. So I'll use myself as an example, actually, because I'm a glaucoma patient dating back 30 years now. And the system has failed me. I've gone blind in my left eye. I've gone through 4 glaucoma doctors. And the problem with the system right now is the emphasis is so much on the bottom line and not the patient, that every time I try to have a conversation with my provider, I can't have that conversation. That's something that would change dramatically. They're on the clock. They have quotas. They actually have back doors where they go weave in and out of the office, so they don't they don't walk in the hallway and perhaps are going to be confronted by a patient. There's so much fear in the business right now. After I lost sight in my left eye, I had tried to reach my primary glaucoma guy for 2 days in a row. He never called me back ever, and my vision went dead. I went blind over the weekend. I then kept my appointment, which was set for 2 months after. I walked into the office. I told my story to the intake nurse. She was shocked. She was really upset. She said, I've already decided to move into the baking business. I'm going to be baking brownies now and cupcakes. I can't stand what I do. This is a nurse, intake nurse. And then the doctor came into the room, looked at me and said, so how are you doing? I said, not so well. I'm now blind in my left eye. And guess what his response was, Tim?
What was that?
Nothing. He just stared right through me. No response whatsoever. Shocking, but not shocking. He was probably afraid I was coming at him with a lawsuit. And then his nurse assistant in the room was so upset by this exchange that she forgot to take me down after my exam was completed. And I decided to leave the practice, but I had to come back and have my peace and tell this doctor that he had failed me. And so this is what the system has done, is it's turned physicians, it's turned the system inside out. The people are operating out of fear, and their best practices, I mean, the Hippocratic Oath, do no harm. Well, we're doing a lot of harm to ourselves with this medical industrial complex. So the whole idea of the patient's experience, it would be dramatically different. It's not about the money, it's about getting care. It's about getting follow-up care. It's about emphasizing primary care and listening to the patient.
So you mentioned lawsuits, and I'm wondering, I know other doctors who either have gotten sued or fear getting sued, and they'll run additional tests and that sort of thing, which also they said, you know, I have to run these tests even though I don't think that they're necessary because I have to cover myself. How would a single payer plan affect that? Would it change the legal landscape at all?
Oh, absolutely. And Walter, why don't you jump in on this one? I know that we've talked about this quite a bit.
Well, one of the reasons why malpractice suits are so expensive is that not only are you paying for the injury that happened, let's say you lost your vision as an example, and you sue for thousands of dollars, but it's also all the future healthcare costs that might be incurred that goes rolled up in the bill. So it's not just the healthcare loss that you had immediately, it's It's for the next decade and couple decades that you multiply in all those additional medical costs. And if you add up all the future healthcare costs, every one of these malpractice suits become multi-million-dollar malpractice suits. Well, what would happen if we had a single payer plan and all your future healthcare costs are now picked up by the single payer entity? And now when you sue, you may sue for pain and suffering, and there may be the immediate loss, but you don't have to pay for all the future healthcare costs because that's picked up by the healthcare system. And the result is that instead of having multi-million-dollar malpractice suits, they're much more reasonable. I mean, not that there shouldn't be some compensation for the person, but I mean, the fact that their future healthcare coverage is guaranteed by the single payer plan actually makes a huge difference, and it reduces dramatically the malpractice lawsuits that doctors have to pay premiums on, and they don't have their overhead costs are dramatically lower. Canadian doctors, their malpractice premiums are a fifth or a tenth of what they are in America. I mean, it's just dramatically different.
Yeah, that's really. I mean, it seems to me that everybody's working for the insurance companies here, and that they're making all the decisions on healthcare, whether or not somebody gets covered, whether they get dropped, how much everything's going to cost. And then doctors are in a position where they're afraid they're going to get sued. It just seems that everything's more expensive because of some middleman that doesn't provide any services whatsoever. But so, I've heard say that it's important to have state single payer efforts rather than a national Medicare for all. Is that true? And if so, why?
Not rather than, but in addition to.
Okay.
We view our work at one pair states. I mean, I'm part of Healthcare for All Philadelphia with Walter, and we work side by side and focus on where are there opportunities right now in California at the state level. Assembly Bill 1400 has just now been given a passage through to begin hearings, and
that's CalCare, correct?
Yes, right. This is a very exciting development. Oregon is making tremendous progress. Washington State is making tremendous progress. Washington State may actually be leading right now in potentially attaining or achieving a universal healthcare system, guaranteed, comprehensive, quality healthcare for all. Same thing as single payer, same thing as Medicare for all. But the state efforts are really, Tim, a nod to the fact that in this country, in the United States, we have a federal system of government where power is shared between the national and the states. And more often than not, social, economic, political progress has been achieved first at the local and state levels. If you look at the progressive era, if you look at the New Deal, across the course of our history, most of the initial gains have been established by modeling successes at the local and state level, and then elevating it to the national level. So it's a nod to understanding that, both our history and our Constitution, as well as simply the practicality of all the money that's piled into Washington, D.C., where you have more than 600 pharmaceutical lobbyists, just piling into these members of Congress. You've got so many lobbyists and so much lobbying money and political action committee money and dark money that it really makes it very, very difficult to achieve things at the national level. We have representatives, and I'll leave names out, right here in the city of Philadelphia, who are not doing their job because they're following the money. They're taking the money and they're not representing us. And that's shameful, and that's got to stop. But we have a better chance in more progressive pocket states, like I said, the West Coast, Vermont, Maine, Minnesota, New York, that we can achieve some success, model it, and then it becomes it then has that attractiveness that people are going to say, let's do it like they did it. That's just the way that Canada got to national health care was Saskatchewan. The province of Saskatchewan modeled it, and all the other provinces, either out of jealousy or economic need, jumped in and said, let's take care of it as well.
Great. So it seems to me that we have both an economic problem that is exacerbated by a political problem, which brings me to the question, what are these obstacles to a single payer, statewide or national plan, and how is it that we can overcome them? I know you mentioned the big four, and Chuck and Walter, you mentioned the Partnership for America's Healthcare Future, a big lobbying arm. Is there any way to fight back against these folks?
Well, yes. I mean, they have billions of dollars behind them, and so they try to, influence members of Congress. But if the American people stood up and said, "This system sucks, and we can and demand a better system," and we do that by electing candidates who support Medicare for all, and we get them into office, that can make a huge difference. And we should be demanding that. Right now, HR 1976, which is the Medicare for All Act, has 119 co-sponsors. That's not a trivial number. That's a huge number of House representatives who say, we want Medicare for all for this country. We need to change, we need to get more of them elected so that we can get the 207 or 212 that we need to actually pass the bill.
Great. So can someone listening in, what can they do to help here? Is there, yeah, go ahead.
Yeah, I was going to say, think about what you can do at the local level in connecting with not just healthcare organizations, but also social justice organizations across the board. And I think this is our big problem: is we have to grow the movement. We have to think about healthcare as connected to all health issues. We're talking about gun safety. We're talking about schools. We're talking about education and climate, environment, and so forth. We have to collect all of our people. Right now, our politics are too divided, and we're too tactical. We have to be strategic. We have to think big, because you know that the medical industrial complex is strategic. You know that they've got a communication strategy. We don't really have a very effective one yet, although we're in the development process. But we've got to be thinking more clearly, and we've got to be connecting with more like-minded people. We have to reach out to faith communities. We have to do a better job of connecting ourselves to people who don't necessarily otherwise think that politics is something that's achievable.
Great. This is good to know. Sadly, when we can go on for a while here, but we've reached the end of today's show. I want to thank Chuck Pennacchio and Dr. Walter Tsou for their thoughts on an important topic. Our producer is Jasmine Hanna, station manager Connie Belay. I want to thank you for spending time with us today. Our show is sponsored by Philly Neighborhood Networks. To learn more about us, go to www.phillynn.org. I'm your host, Tim Brown. Catch you next time on Talking in the Neighborhood. And we're out.
Nice job. That was great.
Good job.